Hello everyone, we will be starting with chapter 2 of illustrated textbook of pediatrics. Starting with chapter 2 history and examination. Taking a history introduction. Make sure you have read any referral letter or hospital notes before the start of the consultation. When you greet this child, parents and siblings check that you know the child's first name and gender. Ask how the child prefers to be addressed. Introduce yourself. Determine the relationship of the adults to the child. Establish eye contact and rapport, but keep a comfortable distance. Infants and some toddlers are most secure in parents' arms or laps. Young children may need some time to feel at ease. Observe how the child plays and interact with any siblings present. Do not forget to address questions to the child when appropriate. There will be occasions when the parents will not want the child present or when the child should be seen alone. This is usually to avoid embarrassing older children or teenagers or young adults to impart sensitive information. This must be handled tactfully, often by negotiating to talk separately to each in turn. Give an adolescent the opportunity to talk to you alone. This can be deduced as it is my usual practice to see the adolescent after the parent so he or she knows that confidential information imparted to the doctor has not been disclosed. See the adolescent after the parent so he or she knows that confidential information imparted to the doctor has not been disclosed. Presenting complaints. Full details are required of the presenting symptoms. Start with an open question. Let the parents and child recount the presenting complaint in their own words and at their own pace. Note the parents' words about the presenting complaint, onset, duration, previous episodes, what relieves, aggravates them, time course of the problem, if getting worse, and any associated symptoms. Has the child or the family's lifestyle been affected? What has the family done about it? If describing a rash or an event such as a seizure, parents may have a photograph or video on their mobile phone. These can be very helpful, but you may need to ask for them. Make sure you know what prompted the referral, what the parents think or fear is the matter. Have the parents been searching the internet or discussed it with others? The scope and detail of further history taking are determined by the nature and severity of the presenting complaint and the child's age. While the comprehensive assessment listed here is sometimes required, usually a selective approach is more appropriate. This is not an excuse for a short, slipshod history, but instead allows one to focus on the areas where a thorough, detailed history is required. For example, in a young child with delayed speech, a detailed birth history and neonatal history and details of developmental milestones should be established but would not be appropriate for an adolescent with headaches. Journal inquiry and systems overview. Check for journal health, how active and lively. When were they last their normal self, normal growth? Is the child following their weight and height centiles? Feeding, drinking, appetite, any recent change in behavior or personality? Selected as appropriate. Journal rashes, fever if measured. Respiratory, cough, wheeze, breathing problems, ear, nose, throat, earache, throat infections, snoring, noisy breathing, stridor, cardiovascular cyanosis, exercise tolerance or faints. GIT includes vomiting, diarrhea, constipation, abdominal pain, genitourinary dysuria, frequency, wetting, and toilet trained. Neurological, developmental, vision, hearing, seizures, headaches, abnormal or impaired movements, change in behavior, musculoskeletal, gait, limb pain or swelling, other functional abnormalities, Pubertal development, make sure that you and the parent or child mean the same thing when describing a problem. For example, parents may use the word wheeze to describe any respiratory sound. Smartphones are particularly helpful in pediatric practice as parents will often have photographs showing what they're concerned about or taken videos, for example, of abnormal movements of the limbs or eyes. Past medical history, often easiest to follow in chronological order. Maternal obstetric problems, including antenatal scans and screening bloods. Delivery and birth weight and gestation. Perinatal problems, whether admitted to special care baby unit, jaundice, etc. Immunizations, ideally from the personal child health record. Past illnesses, hospital admissions and operations, accidents and injuries. Medications, check past and present medications, both prescribed and over the counter. Known allergies. Family history, families share houses, genes and diseases. Have any problem members of the family or friends had similar problems or any serious disorder? Any neonatal childhood deaths? Draw a family tree. If there is a positive family history, extend family pedigree over several generations. If there consanguinity. Social history, check relevant information about the family and their community. Parental, occupation, economic status, housing, relationships, parental smoking, marital stresses, who lives with you at home. Adding this to the family tree is a convenient way to document it. Is the child looked after, i.e., under the care of social services? Is the child happy at home? What are the child's preferred play or leisure activities? In an older child, it may be appropriate to take a psychosocial history. Is the child happy at nursery or school? What has been the impact of this illness on the child and family? Are the family eligible to claim any benefits? Is there a social worker involved? This can often be tricky to ask. One approach is to simply ask, do you have a health visitor, a social worker? This should identify if families are known to social services. For example, if the child is subject to a child protection plan. This social snapshot is crucial since many childhood illnesses or conditions are caused by or affected by an adult problem. For example, alcohol and drug abuse, long-term unemployment or poverty, poor, damp, cramped housing, parental mental health disorders, unstable partnership. Drawing social arrangements on a family tree. Jade, a 3-year-old girl, presents with faltering growth. She has 2 full siblings, but her mother has another 2 older children by the previous partner who gives her no financial support. Her current partner, Simon, is out of work. Chris, his 70-year-old son from a previous relationship, is also living in the house. This can most easily be understood by drawing the family's social arrangement on the family tree given in the figure. These details could be missed if a full family and social history is not taken. Then some key development milestones in infants and young children. These are considered in detail in next chapter. Normal child development, hearing and vision. Now development, check parental concerns about development, vision, hearing. Key developmental milestones. It is helpful to consider the developmental history in domains as given in the figure. Previous child health surveillance, developmental checks, bladder and bowel control in young children, child's temperament, behavior, sleeping problems, concerns in progress in nursery, school. Look through the personal child health record and approach to examining children. That is adapting to the child's age. Adapt the examination to suit the child's age. While it may be difficult to examine some toddlers and young children fully, it is usually possible with resourceful and imagination on the doctor's part. Baby in the first few months are best examined on an examination couch with the parent next to them. A toddler is best initially examined on his mother's lap or occasionally over a parent's shoulder. Parents are reassuring for the child and helpful in facilitating the examination if guided as to what to do. Preschool children may initially be examined while they are playing. Older children and teenagers are often concerned about privacy. Young people, male and female, should normally be examined in the presence of a parent or nurse or suitable chaperone. Be aware of cultural sensitivities in different ethnic groups. Obtaining the child's cooperation, make eye contact and smile. This will build trust. Even very young children can judge your intentions from your facial expression and attitude. If the child still looks scared, don't just press on, but wait, allowing the parent to reassure them. Get on the child's level and try and engage in play and conversation. Try to make sure that your eye line is at the same height or lower than theirs if at all possible. It is intimidating to have an adult tower over you. Explain what you are about to do and what you want the child to do in language he or she can understand, as the examination is essential, not optional. It is best not to ask for permission, as it may well be refused. Be confident but gentle. Short mock examinations, for example, auscultating a teddy or a parent's hand, may allay a young child's fear. While examining a young child, start at a non-threatening area such as a hand or knee. In general, the more distant the site examined is from the face, the more likely a child is to cooperate. Leave unpleasant procedures such as ear and throat examinations until last. Undressing children, be sensitive to children's modesty. The area to be examined must be inspected fully, but this is best done in stages. Redressing the child when each stage has been completed, it is easiest, kindest, and helpful to ask the child or parent to do the undressing. Warm, clean hands. Hands may be washed before and after examining a child. Warm smile, warm hands, and a warm stethoscope all help. Developmental skills. A good overview of developmental skills can be obtained by watching the child play. A few simple toys such as some bricks, a car, doll, ball, pencil and paper, pegboard, miniature toys, and a picture book are all that is required, as they can be adapted for any age. If developmental assessment is the focus of the examination, it is advisable to assess this before the physical examination, as cooperation may then be lost. Examination in initial observations. Watch before you examine. Careful observation is usually the key to success in examining children. Look before touching the child. Observation will provide information on severity of illness, growth and nutrition, behavior and social responsiveness, level of hygiene and care, severity of illness in the child, sick or well. If sick, how sick. For the acutely ill infant or child, perform the 60-second rapid assessment. Airway and breathing, respiratory rate and effort, presence of stridor or wheeze, cyanosis, circulation, heart rate, pulse volume, peripheral temperature, capillary refill time, disability, level of consciousness. The care of seriously ill child is described in chapter 6. Measurements. Abnormal growth may be the first manifestation of illness in children. Faltering growth is a red flag sign. Always measure and plot growth on centile charts for weight, noting previous measurements from personal child health record. Length in infants if indicated, or height in older children. Head circumference in infants and older children if there is a neurological development problem. Growth in puberty, further details also as appropriate. Temperature and blood pressure. Approach to examination. Younger children need to be opportunistic. If a baby is quiet, you may choose to auscultate the chest before undressing the infant, which may make the infant cry. There is no strict order, and there is no right place to stand or sit when examining an individual child, but by the end of the examination, a thorough examination needs to have been performed. Some components of the examination, like abdominal examination, are easy to do from the child right hand side if you're using your right hand to palpate for organomegaly. General appearance: the face, head, neck, and hands are examined. The general morphological appearance may suggest a chromosomal or dysmorphic syndrome. Is the head large or small? In infants, palpate the fontanelle and sutures. Look for any congenital abnormalities. Is the child dehydrated, jaundiced, or anemic? Respiratory system cyanosis: is the child pink or blue, or are they on an oxygen saturation monitor? Central cyanosis is best observed on the tongue. Clubbing of the fingers and toes. Clubbing is usually associated with chronic suppurative lung disease, for example, cystic fibrosis or cyanotic congenital heart disease. It is usually seen in inflammatory bowel disease or cirrhosis. It is obvious when severe but can be difficult to detect when mild. It starts with fluctuation, bogginess of the nail bed. Tachypnea: count the rate or determined from the monitor. Rate of respiration is age dependent. Dyspnea: labeled or increased work of breathing from increased air resistance. Increased work of breathing is judged by nasal flaring. Expiratory grunting to increase positive and expiratory pressure. Use of accessory muscles, especially sternomastoid. Retraction, recession of the chest wall from use of suprasternal, intercostal, and subcostal muscles. Difficulty speaking or feeding. Chest shape: hyperexpansion or barrel shape, for example in asthma. Pectus excavatum, hollow chest, or pectus carinatum. Pigeon chest, Harrison sulcus, in drawing of the chest wall for long-term dramatic tug or from poorly controlled asthma. Asymmetry of chest wall movements. Palpation: chest expansion. If it looks abnormal, you can check with a tape measure. This is 3 to 5 centimeter in school-aged children. Check for symmetry. Trachea: checking that it is central is seldom helpful and is disliked by children. To be done selectively. For example, if concerned about mediastinal shift in pneumothorax. Location of apex bead to detect mediastinal shift. Percussion needs to be done gently, comparing one side with the other using middle finger. In infants, only informative when clear-cut signs. Localized dullness, collapse, consolidation, fluid. Auscultation, ears, and stethoscope. Note quality of breathing and symmetry of breath sounds and any added sounds. Cough, note its character. Hoarse voice, hoarseness of voice, abnormality of the vocal cords. Stridor, harsh, low-pitched, mainly inspiratory sound from upper airway obstructions. Harsh breath sounds from the upper airways are readily transmitted to the upper chest in infants. Breath sounds normal are vesicular. Bronchial breathing is higher pitched and the length of the inspiration and expiration equal. Prolonged expiratory phase usually denotes gas trapping, as in asthma. Wheeze, high-pitched expiratory sound from distal airway obstruction. Crackles, discontinuous moist sounds from the opening of the bronchioles. Abnormal respiratory sounds may be inaudible in a child who's taking shallow, rapid breaths, but may be detectable when the child takes big breaths. Now, cardiovascular system, cyanosis. Observe the tongue for central cyanosis. Clubbing of fingers and toes. Check if present. Pulse, check rate. Rhythm, sinus. Arrhythmia, variation of pulse rate, respiration is normal. Now let us see at the table. Table shows us respiratory system. First it shows us clubbing of the fingers. There is increased curvature, loss of nail angle and fluctuation. This child has cystic fibrosis. And then in table 2.1, respiratory rate in children and neonates, normal is 30 to 50, and tachypneic is more than 60. Infant is 25 to 40, tachypneic is more than 50. Young children is 25 to 35, and tachypnea is more than 40. And older children is 20 to 25 normal, and tachypneic is more than 30. Chest signs of some common chest disorders. Bronchiolitis has labored breathing, hyperinflated chest, and chest recessions. Percussion is hyperresonant. Auscultation, fine freckles in all zone visas may or may not be present. And in pneumonia, reduce on affected side, rapid shallow breaths, and percussion is dull, and auscultation is bronchial bleeding and crackles. Asthma is reduced but hyperinflated, use of accessory muscles, chest walls retraction. Percussion is hyperresonant and auscultation is wheeze. Croup is stridor and chest wall retraction. Percussion is normal and auscultation stridor from upper airways. And there is a picture of hyperexpanded chest from chronic obstructive airway disease. The boy has severe asthma. Infants, now the bullet points. Infants in pneumonia, tachypnea may be the only respiratory sign, may not have any abnormal signs on auscultation. Tachypnea is the most sensitive marker of respiratory disease, but is less specific than chest recessions. Sputum is rarely produced by children as they swallow it. The main exception is suppurative lung disease from cystic fibrosis. Volume of the respiratory system while we were doing the inspection, and volume small in circulatory insufficiency or aortic stenosis, increase in high output states, stress, anemia, collapsing in patent ductus arteriosus, and aortic regurgitation. In inspection, look for respiratory distress, precordial bulge caused by cardiac enlargement, ventricular impulse visible if thin hyperdynamic circulation or left ventricular hypertrophy. Operative scars, mostly median sternotomy or left lateral thoracotomy. Palpation identifies apex at 4th to 5th intercostal space, mid-clavicular line, but not palpable in some normal infants, plump children, or dextrocardia. A thrill, which is palpable murmur, heave from ventricular hypertrophy at, for example, at lower left sternal edge from right ventricular hypertrophy. Now there's a table of cardiovascular system. Normal resting pulse rate in children less than 1 year is 110 to 160 beats per minute. 2 to 5 years in 95 to 150 beats per minute. 5 to 12 years 30 to 120 beats per minute. More than 12 years 60 to 100. And the splitting of second heart sound is easily heard in children. Figure 2.7. A is closure of aortic valve and P is closure of pulmonary valve. And now the bullet points. Features of heart failure in infants: poor feeding, faltering gait, sweating, tachypnea, tachycardia, gallop rhythm, cardiomegaly, and hepatomegaly. Features suggestive that a murmur is significant, conducting all over the precordium, loud, thrill, equals grade 4 to 6 murmur, any diastolic murmur accompanied by other abnormal cardiac signs. Next is percussion. Cardiac border percussion is really helpful in children. You may wish to percuss the upper border of the liver, though you are going to feel the lower border later. Auscultation, listen for heart sounds and murmurs. Heart sounds, splitting of second heart sound is usually easily heard and is normal. Fixed splitting of second heart sound in atrial septal effects. Third heart sound in mitral area is normal in young children. Murmurs, timing, either systolic, diastolic, continuous, duration, mid-stolic, ejection, systolic, and pansystolic. Loudness, systolic murmurs graded as 1 to 2, soft, difficult to hear. 3, easily audible, no thrill. 4 to 6, loud with thrill. Site of maximum intensity, mitral, pulmonary, aortic, tricuspid areas. Radiation to neck in aortic stenosis, to back and coarctation of aorta or pulmonary stenosis. Draw your findings. that will be seen in chapter 18, cardiac disorders. Hepatomegaly. Hepatomegaly, an important sign of heart failure in infants, and infant's liver is normally palpable 1 to 2 centimeters below the costal margin. Femoral pulses, always palpate for femoral pulses in neonates. In coarctation of aorta, the femoral pulses are often difficult to palpate, while upper limb pulses are easy to feel. In older children, there is a brachiofemoral delay. Blood pressure, bullet point, heart disease is more common in children with other congenital abnormalities of syndrome, for example, Down or Turner syndrome. Now, abdominal examinations performed in 3 major clinical settings, part of the routine clinical examination: acute abdomen and recurrent abdominal pain, distension, constipation. Associated signs: if not already done, examine the eyes for signs of jaundice and anemia, the tongue for cyanosis, the mouth for oral health and ulcers, the fingers for clubbing. Inspection: the abdomen is protuberant in normal toddlers and young children. Occasionally, abdominal distension is caused by a grossly enlarged liver and or spleen or kidney or mass. Other abdominal signs are dilated veins in spina nevi. In liver disease, abdominal striae, operative scars. Draw a diagram. Always draw a diagram for operative scars. Peristalsis from pyloric stenosis, intestinal obstruction. Are the buttocks normally rounded or wasted, as in malabsorption, for example, celiac disease or malnutrition? Palpation: the abdominal wall muscles must be relaxed for palpation. Kneel down so your face is level with the child's face. Use warm hands. Explain. Relax the child and keep the parent close at hand. First ask if it hurts. Palpate in a systematic fashion. Systematic fashion is liver, spleen, kidneys, bladder, through the 4 abdominal quadrants, first gently in each quadrant, then more deeply in each. Ask about tenderness. Watch the child's face for grimacing as you palpate. A young child may become more cooperative if you palpate first with their hands or by putting your hand on top of theirs. Tenderness location: localized in appendicitis, hepatitis, pyelonephritis, generalized in mesenteric adenitis and peritonitis. Guarding: often unimpressive or direct palpation in children. Pain or coughing or moving about. Walking, bumps during car journey. Suggests peritoneal irritation. Back bend on walking may be from psoas inflammation in appendicitis. By incorporating play into examination, more subtle guarding can be elicited. For example, a child will not be able to jump on the spot if they have localized guarding. You could ask them to blow out their tummy as big as they can, then suck it in as far as they can. This will elicit pain if they have peritoneal irritation. Hepatomegaly, normal size is shown in figure. This figure is normal findings. The liver edge is 1 to 2 centimeters below the costal margin in infants and young children. The spleen may be 1 to 2 centimeters below the costal margin in infants. Now, in table, causes of splenomegaly: infection, congenital infectious mononucleosis, hepatitis, malaria, parasite infection. Hematological: sickle cell anemia, thalassemia, liver disease, either liver disease due to chronic active hepatitis, portal hypertension, polycystic disease, maybe malignancy, leukemia, lymphoma, neuroblastoma, Wilms tumor, hepatoblastoma, metabolic, glycogen and lipid storage disorders, and mucopolysaccharidosis. CVS is heart failure, apparent chest hyperexpansion from bronchiolitis or asthma. Bullet point on examination: the abdomen, inspect first, palpate later. Superficial palpation first, deep palpation later. Guarding may be subtle in children. Silent abdomen, serious. Immobile abdomen, serious. Cause of splenomegaly: infection, either viral, bacterial, protozoal, malaria, or leishmaniasis, parasite, infective endocarditis, hematological, hemolytic anemia, malignancy, leukemia, lymphoma, other portal hypertension, systemic juvenile idiopathic arthritis, that is Still's disease. To identify hepatomegaly, palpate from right iliac fossa, locate edge with tips and fingers, sides of the fingers. Edge may be soft or firm, unable to get above it. Move with respiration. Measure in centimeter extension below costal margin in mid-clavicular line. Percuss downward from the right lung to exclude downward displacement due to lung hyperinflation, for example in bronchiolitis. Liver tenderness is likely to be due to inflammation from hepatitis. The causes of hepatomegaly were listed as above. Splenomegaly. To identify splenomegaly, palpate from right iliac fossa. Edge is usually soft, unable to get above it. Notch occasionally palpable if markedly enlarged. Move on respiration. Ask the patient to take a deep breath. Measure size below costal margin in centimeter in mid-clavicular line. If uncertain whether it is palpable, use bimanual approach to spleen. Turn child onto right side. A palpable spleen at least twice its normal size. Causes splenomegaly as given in the table above. Lung hyperexpansion in bronchiolitis or asthma may displace the liver and spleen downwards, mimicking hepatosplenomegaly. Kidneys, they are not usually palpable beyond the neonatal period unless enlarged or abdominal muscles are hypotonic. On examination, palpate by balloting bimanually. They move on respiration, they can get above them, unlike the spleen or liver where you cannot palpate the upper part. Tenderness implies inflammation. Abnormal masses, Wilms tumor, renal mass sometimes visible, does not cross midline. Neuroblastoma, irregular firm mass may cross midline. The child is usually very unwell. Fecal masses, mobile, non-tender, indentable, often in left iliac fossa. Intussusception, acutely unwell. Mass may be palpable, most often in right upper quadrant. Percussion liver is dullness, delineates upper and lower border. Record span. Spleen, dullness delineates lower border. SIT, shifting dullness, percuss from most resonant spot to most dull spot. Auscultation, not very useful in routine examination but important in acute abdomen. Increased bowel sounds, intestinal fluxion and acute diarrhea. Reduce absent bowel sounds, paralytic ileus, peritonitis. Genital area is examined routinely in infants and young children, but in older children and teenagers, this is done only if relevant. For example, vaginal discharge, is there any inguinal hernia or a perineal rash? In males, is the penis of normal size? Is there hypospadias or gaudy? Head of the penis curves downward or upward at the junction of the head and the shaft of the penis. Is the scrotum well developed? Are the testes palpable with one hand over the inguinal region? Palpate with the other hand. Record if the testis is distended, retractile or impalpable. Is there any scrotal swelling, hydrocele or hernia? In females, do the external genitalia look normal? Rectal examination not performed routinely. Does the anus look normal? Neurology, neurodevelopment, brief neurological screen. A quick neurological and developmental overview should be performed in all children when doing this. Use common sense to avoid unnecessary examination. Adapt it to the child's age. Take into consideration the parent's account of developmental milestones. Watch the child play, draw or write. Does vision and hearing appear to be normal? Are the manipulative skills normal? Can he walk, run, climb, hop, skip and dance? Are the child's language skills and speech satisfactory? Are the social interactions appropriate? In infants, assess primarily by observation. Observe posture and movements of the limbs when picking the infant up. Note the tone, The limbs or body may feel normal, floppy, hypertonic, or stiff. Head control may be poor with abnormal head lag or pulling to sitting. Most children are neurologically normal and do not require formal neurological examination of reflexes, tone, etc. More detailed neurological examination if the child has a neurological problem, and detailed and systematic neurological examination is required. Cranial nerves, before about 4 years old, you need some ingenuity to test for abnormal or asymmetrical sign. Make it a game. Ask them to mimic you. Smell need not to be tested in routine practice. Can be done by recognizing the smell of a hidden mint sweet or hand towel splashed with hand cleaning gel. Visual acuity. Number 2 is visual acuity for cranial nerve. 2. Visual acuity determined according to age. Direct and conceptual pupillary response tested to light and accommodation. Visual fields can be tested if the child is old enough to cooperate. Cranial nerves 3, 4, and 6. Full eye movement through horizontal and vertical planes. Is there a squint? You may need to hold the chin or head still. Nystagmus, but avoid extreme lateral gaze as it can induce nystagmus in normal children. Cranial nerve 5, clenched teeth and waggle jaw from side to side against resistance. Cranial nerve 7, close eyes tight, smile and show teeth. Cranial nerve 8, hearing, whisper in each ear while supplying white noise with fingers outside the other ear. Ask the child what you have whispered. If in doubt, need formal assessment in the suitable environment. Cranial nerve 9, levator palati, saying look for deviation of uvula. Cranial nerve 10, recurrent religion nerve, listen for hoarseness or stridor. Cranial nerve 11, trapezius and sternocleidomastoid. Power, shrug shoulders and turn head against resistance. Cranial nerve 12, put out tongue and look for any atrophy or deviation. Inspection of face, myopathic face, expressionless, often with ptosis and drooping of corners of the mouth, is suggestive of neuromuscular disease. For example, myotonic dystrophy. Ptosis, unilateral ptosis suggestive of a third nerve palsy. Bilateral ptosis, for example, in myasthenia gravis. Tongue fasciculation in spinal muscular atrophy. Inspection of limbs, muscle bulk, wasting may be secondary to cerebral palsy, meningomyelocele, muscle disorder, or from previous poliomyelitis. Increased bulk of calf muscles may indicate Duchenne muscular dystrophy or myotonic conditions. Contractures or a wind-swept posture suggests increased tone, or a child with hypotonia or restricted movements in utero. Fasciculation of muscles, low motor neuron lesions, muscle tones, tone in limbs. The posture of the limbs may give a clue as to the underlying tone. For example, scissoring of the legs, pronated forearms, fisting, extended legs suggest increased tone. Sitting in a frog-like posture of the legs suggests hypotonia, while abnormal posturing and extension suggest fluctuating tone, dystonia. Assess by taking the weight of the whole limb and then bending and extending it around the joints. Assess the resistance to passive movement as well as range of movements. Increased tone, spasticity in adult adductors and internal rotators of the hips. Clonus at the ankle, increased tone on pronation of the forearms at rest, usually from pyramidal dysfunction. This is different from the led by rigidity seen in extrapyramidal conditions, which, if accompanied by a tremor, is called cogwheel rigidity. Truncal tone in extrapyramidal tract disorders, the trunk and head tend to arch backwards. External posturing in muscle disease and some central vein disorders, the trunk may be hypotonic. The child feels floppy, hypotonic to handle, and cannot support the trunk in sitting. Head lag is best tested by pulling the child up by the arms from the supine position. Power, ask the child to hold his arms out straight with the palms of the hands upward and close his eyes, and then observe for drift or tremor. Power can be graded using the Medical Research Council power scale. Number 5 is normal. Number 4 is weak but active movements against gravity and resistance. 3 is able to move against gravity but not against resistance. 2 unable to move against gravity. Number 1 minimal movement flicker. 0 no movement. Power is difficult to assess in babies. Eliciting Moro reflex can be used to see if there are symmetrical movements of all foreheads, as lack of movement suggests reduced power. Watch for anti-gravity movements and note motor functions. Both provide information about power. From 6 months onwards, watch the pattern of mobility and gait. Watch the child standing up from lying and climbing stairs. This is the figure hypotonic infant when held prone. Infants floss like a rag doll. Marked head lag on the traction of the arms. From the age of about 4 years, power can be tested formally against gravity and resistance, first testing proximal muscles and then distal muscles, power, and comparing sides. Coordination, assess this by finger nose testing. Use mother or teddy's nose to reach out and touch if necessary, asking the child to walk heel to toe, jump and hop, asking the child to build one brick upon another, to using a pegboard or do up and undo buttons. Draw, copy patterns, and write. Sensation, ability to feel light touch can be used as a screening test. If raw sensation is likely, meningomyel, for example, meningomyelocene spinal lesion, transverse myelitis, etc. More detailed sensory testing with wooden stick or neurotrip is performed as in adults. In spinal aquatic equine lesions, there may be a palpable bladder or absent perineal sensation. Reflexes, test with a child in a relaxed position and explain what you're about to do before approaching with a tendon hammer, or demonstrate on a parent or toy first. Brisk reflexes may reflect anxiety in the child or a pyramidal disorder. Absent reflexes may be due to a neuromuscular problem or a lesion within the spinal cord, but may also be due to inexpert examination. Technique, children can reinforce reflexes by biting hard or squeezing their hands to make fists. Plantar response, they are unreliable under 1 year of age. Outgoing plantar responses provide additional evidence of pyramidal dysfunction. Pattern of movement, assessment of walking and running can be incorporated into playing a game. For example, how fast can you run? Children over 5 years of age can usually manage to walk heel to toe. Ask them to walk on a line on the floor as though they were walking on a tightrope. In hemiplegic gait, the child holds one arm flexed whilst dragging the ipsilateral affected leg. A toe-heel pattern of walking. Toe walkers, although often idiopathic, may suggest pyramidal tract corticospinal dysfunction or pelvic girdle neuromuscular weakness. If you are unsure whether a gait is heel to toe or toe to heel, look at the pattern of shoe wear. Examining the wear of shoe soles can also show you if there is asymmetry. A broad-based gait may be due to an immature gait, normal in toddler, secondary to a cerebral disorder or a sign of lower limb weakness. Waddling gait may be due to proximal muscle weakness around the pelvic girdle. Difficulty walking on the heels may suggest foot drop, for example, in hereditary motor sensory neuropathy. Children may develop tight Achilles tendon due to weakness, suggesting hemiplegia or myopathy. Subtle asymmetries in gait may be revealed by Fogg's test. Children are asked to walk on their toes, heels, the outside, and then the inside of their feet. Watch for the associated movements in the upper limbs. Observe them running. Look for asymmetry. Ask the child to stand up from lying down supine. Children up to 3 years of age will turn prone in order to stand because of poor pelvic muscle fixation. Beyond this age, it suggests proximal neuromuscular weakness, for example, Duchenne muscular dystrophy or low tone, which could be due to a central vein cause. Need to turn prone to rise or lateral as weakness progresses. To push off the ground with straighten arms and then use hands to walk up the legs to stand is known as Gower sign, as that we've seen in figure. To complete the neurological examination, examine the child's spine, check the base of the spine for skin lesions such as birthmarks and hair, which may be suggested of spina bifida occulta or a tethered cord. Bones and joints. A rapid screen to identify disorders: the musculoskeletal is pediatric gait, arms, legs, spine. P-GALS in figure if an abnormality is found. A more detailed regional examination of the affected joint as well as the joint above and below should be performed. P-GALS musculoskeletal screening for school-aged children. Differences from adult GALS highlighted in bold. Screening questions: do you or your child have any pain or stiffness in your joints, muscles, or on your back? Do you or your child have any difficulty getting yourself dressed without any help? Do you or your child have any difficulty going up and down stairs? Posture and gait. Observe standing from front, back, and side. Observe walking. Walk on your tiptoes. Walk on your heels. Arms. Put your hands out straight in front of you. Turn your hands over and make a fist. Arms. Pinch your index finger. Pinch your index finger and thumb together. Touch the tips of your fingers with your thumb. Squeeze the metacarpophalangeal joints for tenderness. Put your hands together, palm to palm. Put your hands back to back. Reach up and touch the sky. Look at the ceiling. Pediatric gait, arm, legs, spine, P-GALS, musculoskeletal screening for school-age children. P-GALS musculoskeletal screening for school-age continued. Difference: arms, put your hands behind your neck. Legs, feel for effusion at the knee. Bend and then straighten your knee. Active movements of knees and feel for crepitus. Passive movement of hip. Temporomandibular joint. Open your mouth and put 3 fingers in your mouth, neck and spine. Touch your shoulder with your ear. Observe lateral flexion of cervical spine. Bend forward and touch your toes. Observe curve of the spine. Regional musculoskeletal assessment. Look for signs of discomfort: skin abnormalities, rashes, scars, bruising, colors, nail abnormalities, limb alignment, leg length, muscle bulk, evidence of asymmetry, bony deformity, soft tissue, joint swelling, muscle changes. Feel for each joint, long bones and neighboring soft tissues. Palpate along bones and joint line for tenderness. Feel for warmth and flexural information. Delineate bony or soft tissue swelling. Check for joint effusions, most readily at the knee. Move for each joint. Ask the child to move the joint first. Active movement. Observe for discomfort, symmetry, and range of movements. Passively move the joint, noting range of any restriction of movement. Compare sides but note bilateral changes. Lateral and rotational movements may be as important as flexion and extension function. For lower limb joints, check gait. For small joints such as hands, check grip. Neck. Thyroid. Inspect swelling uncommon in childhood, occasionally at puberty. Palpate from behind and front for swelling. Nodule, thrill, auscultate if enlarged. Look for signs of hypo or hypothyroidism. Lymph nodes. Children often have easily palpable lymph nodes, particularly the interior cervical, inguinal, and axillary region. Bilateral anterior cervical lymph nodes up to 2 cm in diameter are often found in older healthy children or if experiencing or recovering from an upper respiratory tract infection. Bilateral axillary nodes up to 1 cm, inguinal nodes up to 1.5 cm in diameter are also found in older children. They may be encountered in younger children with eczema. Generalized lymphadenopathy may be present with viral infections, for example, exanthems, or infectious mononucleosis, or systemic diseases, for example, juvenile idiopathic arthritis or Kawasaki diseases. Supraclavicular nodes of any size at any age, or nodes that are firm, non-tender, of a variable size and matted together, warrant further investigation as they can be associated with malignancy. Erythema, warmth, tenderness, and fluctuation of a node suggest lymphadenitis of infected origin. Nodes of variable size and consistency. Is it TB? Eyes. Examination inspects eyes, pupil, irids, and sclera. Are eye movements full and symmetrical? Is nystagmus detectable? If so, may have ocular cerebellar cause, or testing may be too lateral to the child. Are the pupils round? Absence of posterior synechiae. Equal, central, and reactive to light. Is there a squint? Epicanthic folds are common in Asian ethnic groups. Ophthalmoscopy. In infants, the red reflex is best seen from a distance of 20 to 30 centimeter. Partial or complete absence of red reflex occurs in corneal clouding, cataract, and retinoblastoma. Phonoscopy requires experience and cooperation. In infants, Mrcpch are needed, and an ophthalmological opinion may be required. In older children with headaches, diabetes mellitus, or hypertension, optic fundi should be examined. Mrcpch are usually not needed. Ears and throat. Examination is usually left until last, as it can upset a previously cooperative child. Explain what you're going to do, show the parent how to hold, and gently restrain a younger child to ensure success and avoid possible injury. Ears. Examine ear canals and drums gently, trying not to hurt the child. Look for anatomical landmarks or the eardrum, and for swelling, redness, perforation, dullness, and fluid. Throat. Rapidly observe the tonsils, uvula, pharynx, and posterior palate. Older children, 5-year plus, will open their mouth as wide as possible without a spatula. Spatula is fine for young children. Look for redness, swelling, pus, or palatal petechiae. Also check the teeth for dental caries or other gross abnormalities. Measurement of blood pressure. Cuff more than 2/3 upper arm, smaller cuff give artificially high readings. Age, upper limit of normal systolic blood pressure 1 to 5 years, 110 millimeter of mercury, and 6 to 10 years, 120 millimeter per mercury. Communicating with children. Throughout the consultation, make sure that your communication with the child is appropriate for the child's age and stage of development. Investigations during consultations. Blood pressure. Blood pressure may be measured in acutely unwell children as part of assessing circulation. It should also form part of assessment whenever the blood pressure may be abnormal, for example, when assessing a child with renal, cardiac diseases, diabetes mellitus, is overweight or obese, receiving drug therapy which may cause hypertension, for example, corticosteroids, and some neurological presentations or disorders, for example, headache. Hypertension is considered in more detail in chapter 19. Kidney and urinary tract infections. Sphygmomanometer. When blood pressure is measured with a sphygmomanometer, show the child that there is a balloon in the cuff and demonstrate how it is blown up. Use largest cuff which fits comfortably, covering at least 2/3 of the length of the arm. The child must be relaxed and not crying. Systolic pressure is easiest to determine in young children, and clinically the most useful. Diastolic pressure is when the sound disappears, may not be possible to discern in young children. Measurement must be interpreted according to a centile chart for gender and height. Blood pressure is increased by tall stature. Charts relating blood pressure to height are available and preferable. However, for convenience, charts relating blood pressure to age are often used. An abnormally high reading must be repeated with the child relaxed on at least 3 separate occasions. The lowest value is used. Urine analysis using a dipstick required to identify protein, blood, and glucose ketones in the urine. The presence of leukocytes and nitrites may assist with screening for a urine infection. In infants and young children, obtaining an uncontaminated sample for microscopy culture and sensitivity to identify urinary tract infection can be problematic. This is considered in chapter 19. Peak flow or lung function test. Measuring peak flow or obtaining spirometry is a part of respiratory examination in school age children. It can be performed in most children from 5-year-old is reliable. In most 7-year-olds, it is most often used to monitor control of asthma. Summary of the management plan. By the end of consultation, have you covered the ideas concerning expectation eyes of the child and parents, not only for the consultation but also about the attitude to illness in general. Provides a better understanding of where the family is coming from. If you go one step further and incorporate the information into your management plan, you are more likely to be in tune with the family's way of thinking. This might include ideas. What do you think is the matter? Concerns. What particular worries or concerns do you have? Expectation. What are you hoping that we might be able to do for you? Finally, summarize the key problems in the physical, emotional, social, and family terms if relevant. List the diagnosis and possible differential diagnosis. Draw up a management plan to address the problem, both short and long term. This could be reassurance, a period of observation, performing investigations, or therapeutic intervention. Provide an explanation to the parents and child if old enough. Consider providing further information, either written or on the internet. If relevant, discuss what to tell other members of the family. Consider which other professionals should be informed. Write a brief summary in the child's personal child health records. Ensure your notes are dated and signed. Acknowledgement. We would like to know. Okay, these are the acknowledgements. And summary. In taking a history and performing clinical examination, the child's age is a key feature. It will determine the nature of the problem, how the consultation is conducted, the likely diagnosis and management. The interview environment should be welcoming with suitable toys for young children. Most information is usually obtained from focus history and observation rather than detailed examination. Although examination is also important, check growth, including charts in personal child health record and development. With young children, be confident but gentle. Do not ask their permission to examine them, or they might say no and leave unpleasant procedures, ears and throat until last. Involve children with the consultation as appropriate as to their age. Bullet point: always consider if there are child protection issues. Do you have any concern that this child is not adequately cared for or at risk? Ask. Any concerns may be reported to a senior member of the pediatric team. Now, the reason for talking with children, table 2.6 in your book. Why talk to children when you can get the information from the parent? The reasons are to establish rapport, to obtain the child's own views about their problems, to know how the child feels about their health and life, to reduce anxiety and fear, and to improve compliance with assessment and treatment, to determine the presence of associated emotional or psychiatric problem. Thought processes: preschool child, 2 to 5 years. I'm asleep, so everyone is asleep. They are at the center of their world. When I fell, the floor hurt me. Objects are alive. My toy elephant is crying because the other elephant won't play with him. Involvement in pretend play. School age child, 6 to 11 years. I want to watch TV, but George is on the PlayStation. I'll ask Dad how much longer she's allowed. Concrete problem solving. Will Emmy still be my friend? And when I move schools, worries about the future. I know Mom gets very upset when I wet the bed, but I can't help it. Understands the feelings of others. Adolescent, 12 to 18 years. I can handle things without Mom's help. Seeking autonomy and separation. Should our country be at war? Develops concern about social issues. Effect on the way we talk to them. Preschoolers, and which are 2 to 5 years old, use short concrete questions within their immediate experience to avoid yes no answers. Use a choice of options. For example, when you go to nursery, what do you like to do? Draw a dress up or something else. Use toys or puppets while interviewing, for example, to represent different people in the child's life. And then school age child, 6 to 11 years, use familiar examples of experiences of others to explore the child's feelings and behavior. For example, when a boy was bullying another boy at school, he came to see me so we could talk about how he controls his temper. Do you ever get angry and bully others? You can get at their hopes and dreams by asking them, if I was a magician and could give you 3 wishes, what would they be? The next effect is adolescent 12 to 18 years should be given an opportunity to be seen alone, as they may have problems and difficulties not known to the parents and that the adolescent does not want to share with them. Upsetting thoughts can be explored in some adolescents using metaphors. So this is the end of chapter 2. Thank you.